And so I'd like to start by acknowledging that the University of Manitoba is located on Treaty 1 territory and the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. We respect the treaties that were made on these territories, acknowledge the harms of the past and ongoing colonial violence perpetrated against Indigenous peoples through our systems and institutions. We dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration, and recognize and appreciate the resilience and patience of Indigenous peoples who continue to share their wisdom and knowledge with us. We commit ourselves to learning about the impacts of colonization, residential schools, and cultural genocide, and the role we as white settlers continue to play in supporting white supremacy and the status quo. Specifically in the context of patient engagement, we are learning to respect Indigenous ways of knowing and recognize that these represent the origins of scientific discovery and collaboration, and unlearning certain ideals of Western empirical knowledge instilled in us through formal education in order to gain a more holistic understanding of our world and ourselves. So what we will be chatting about in today's session, I'll start by discussing what is patient engagement and then what patient engagement isn't, also quite important, why we should engage, especially in these fields, and the levels of engagement, kind of a primer on some of the more deeper content we go through in the series. And then I'll share some tools and resources, and Victoria will talk to you about some examples of engagement in data science, tech, and engineering. And then we'll share with you about the prep ward, which is still open for these fields until January 20th, I believe. And so because this is an accredited program, I do need to disclose that myself and Victoria and Carolyn are employees of the Georgian Fayee Center for Healthcare Innovation, or CHI. I'm also a member of the Canadian Agency for Drugs and Technology in Health's Patient and Community Advisory Committee. And we have no other conflicts to disclose. So at CHI, one of our key mandates is supporting patient-oriented research. So this means research that engages patients as partners in decision-making about the research process, focuses on patient-identified priorities, improves patient outcomes, is conducted by multidisciplinary teams in partnership with relevant stakeholders, and bolded, underlined, we should try and aim for all of these, aims to apply the knowledge generated to improve healthcare systems and practices. And when we talk about patient engagement, we are in part funded by the Strategy for Patient-Oriented Research through the Canadian Institutes of Health Research, and they define patient engagement as the meaningful and active involvement of patients in the governance of research. So that's around decision-making, perhaps things like steering committees, strategic planning, ethics review committees, and so on. In priority setting of research, thinking about things like outcomes and the conduct of research, and knowledge translation of research. We can also look at it through a different lens, in that patient engagement is research that is carried out with or by members of the public rather than to, about, or for them. And the organization involved in the UK that has been engaging patient partners in health research since 1997 defines it this way. And this came out of the disability activism movement in the 90s, nothing about us without us. And our definition here at CHI of patient engagement in health research, this is people with lived and living, so past and current experience of a health issue. This can include patients themselves. It can be informal caregivers, family members, friends, and communities, having a say in decision-making about the research process. And when we think about what it is, it's also important to define what it isn't, because there can be some misconceptions. The language can be vague. It differs in different areas and different fields. So patient engagement does not mean people being recruited to a clinical trial or other research study to take part in the research. Those are participants. It's not people completing a questionnaire or participating in a focus group as part of a research study. Data is being collected about them. They're still participants. It's not science festivals open to the public with debates and discussion about research. This is a fantastic way to share your work with the public and get more interest and help people understand what you're doing, but it's not engagement. An open house at a research center where you're inviting folks to come find out about research. Again, that's sharing information, raising awareness of research through media, sharing research findings to participants, colleagues, or members of the public. These are all kind of pushing information out or involving people that you're collecting data about. And that key part of research decision-making that folks are being involved in is not included in these. So that's why we don't consider them patient engagement. And now, why should you engage? So we'll give you some compelling reasons, and we'll start by going through the research process and the different parts. But first of all, some of the core principles of patient engagement that we share are that engagement of people with lived and living experience of health conditions can improve health outcomes and enhance healthcare systems. It can increase the quality, appropriateness, acceptability, transparency, and relevance of research, and ensure that the health research that we do addresses issues that are actually of importance to people living with these conditions. And when we talk to quantitative researchers, which I'm sure many of you are or work with, it can be difficult to think about how partners can really inform work that seems to be on the surface just numerical data. In my own education, biochemistry and physiology, I was taught to aim to be an objective observer of experiments. But as we're learning, the data and ourselves may not be so objective as we hope. This quote from Walter and Anderson from their book, Indigenous Statistics, a Quantitative Research Methodology, describes it quite well. So statistics are powerful persuaders. As systematically collected numerical facts, they do much more than summarize reality in numbers. They also interpret reality and influence the way we understand society. The researchers who create statistics leave their mark on them, not just because people are biased in overt or conscious ways, but also because social, cultural, economic, and political perspectives infuse the research data, even when we think we are just counting people. Some important takeaways from this and similar bodies of work are that researchers, all of us who create statistics, are human. We have our own biases informed by these perspectives. This influences the research data. It's inevitable. Population statistics create the accepted reality of things most of us think they are merely describing. The social, cultural, and economic phenomena that are chosen for inclusion in our research, and also those which are excluded, provide a reflection of our society's changing social, cultural, and economic priorities and norms. And we've had a number of projects where people with lived and living experience have been able to interpret quantitative findings like stats by looking at the story they're telling and what gaps there might be in that story. So the context in which these findings occur, and whether the story these findings tell resonates with the stories of themselves and their own experiences. So thinking about the research process, some reasons we might want to engage. This can help to identify research priorities that matter most to people living with the health condition being researched. For example, in a rheumatoid arthritis study, researchers initially felt the #1 priority for people with lived experience was pain management. But when they engaged patient partners in a research priority setting exercise, they actually discovered that fatigue was the #1 priority. And so they changed the research project to reflect this. It can help shape and clarify research questions so they reflect the needs and concerns of people with lived and living experience. For example, in a mental health study, people with lived experience helped craft the study name and materials to reduce the potential for stigma and to reframe the goal of the study as a movement toward emotional well-being rather than away from a mental health challenge. The anticipated benefit of this input is improved recruitment in the study and greater acceptance of the study by the community where it's happening. Sorry, it's having a technical error there. We can also use patient engagement to help ensure that the methods we propose for a study are appropriate, acceptable, and sensitive to the very real context of people's lives. For example, in a large pragmatic study comparing surgery to antibiotics, over 800 patients were surveyed about their preference for these treatment options, and input was used to shape the proposal, including changing the study inclusion criteria, study logistics, and criteria for failure for one of the arms. Another example is a fall prevention study where caregivers of aging patients who had experienced falls served as representatives on the project's data safety monitoring board. And in this capacity, they were able to offer interpretations of benefit, risk, and data analysis from a lived experience perspective. Patient engagement can also help ensure our research uses outcomes that have true meaning to people with lived and living experience. Stroke survivors serving as patient partners on a study about a new drug identified home time, or the number of days when a patient is living at home, not hospitalized or in another institution, as an important new outcome for the study. Can help ensure that the language and content of the information provided to participants in studies is appropriate and accessible. This might be surveys, questionnaires, consent forms. An example is a chronic pain study where the informed consent document was developed with patient partners to make it more understandable to study participants. And this helped to improve recruitment because participants or potential participants felt more informed and comfortable about the study. We can also help increase participation in a research study by making sure the research is appropriate and acceptable to potential participants, improving the info provided, like I mentioned, so people can make better informed choices, and helping to include voices that are traditionally less heard in health research. One example here is a pediatric surgery study where parent partners shared that were they being approached to participate in the study, they'd actually feel more comfortable if the person discussing the risks and benefits of surgery and involvement in the study was a surgeon themselves. So when that adjustment was made to the protocol, rates of recruitment increased. And you may even have partners involved in collecting data. This is particularly common in qualitative research or participatory action research. For example, a peer reviewer may help collecting much richer data as participants might feel more open to sharing experiences with someone who has a similar story and experiences. Partners might also be involved in analyzing data with their unique perspectives and potential to notice things that researchers without that lived and living experience might miss. This can help to avoid potential gaps in the story the data can tell. There's also the involvement of people with experience on data safety monitoring boards, as mentioned in that fall prevention study. And additionally, partners may be involved in interpreting findings, identifying pieces that are relevant to their lived and living experience, and informing recommendations that can directly impact the lives of patients, caregivers, and communities. For example, in a project using administrative data looking at substance use, researchers were working on creating summaries of the data they found and wanted people with lived and living experience to help interpret the findings. So they used a storytelling approach to find out what that data really meant to them, what story it was telling, and how this compared to their realities and the stories of people they know and love who use substances. This helped the research team to get a more clear picture of the situation and perceived needs that can then help inform decision and policymaking programs to support people struggling with substance use. So providing some context, some story, some real world examples of what this data might mean. It can also help to co-develop ways to share your research findings with other patients, caregivers, families, and communities. This may include having partners as co-presenters or even keynote speakers at conferences or symposia, or even in a classroom or cohort of students who may not have much real-world experience. It can also include co-developing guidelines or infographics to inform clinical practice or policy, as well as co-authorship on peer-reviewed publications. And though knowledge translation often occurs once we've found the data and we've done analysis, involving people with lived experience in the early stages can help you figure out how to explain your work in lay language from the very start. And this will really help you prepare to share your work with the wider public in those later stages. And engaging at any stage of your project or career can be beneficial. As you build relationships and communicate with people who have lived and living experience, you'll get to learn more about different perspectives, systemic barriers people face, and their needs. And this will inevitably lead you to identify new and novel avenues of research. We've heard anecdotally from clinician researchers how involving patients in research decision-making, particularly around outcomes of interest, has sparked entirely new areas of research they wouldn't have considered without engaging. For example, in a study following patients after a major thoracic surgeries, in addition to important clinical outcomes that we would expect to see, patients identified key quality of life indicators that were important to them. Things like being able to go for a walk after dinner or use stairs regularly. In a study with survivors of sepsis, patient involvement provoked ideas beyond those clinical measures related to mortality and morbidity, leading, in fact, to an entirely new study examining the impact of sepsis on frailty. And then finally, we engage to help ensure that research reflects the concerns, interests, and values of those with lived and living experience, and that money and resources are used appropriately. We see this particularly in Indigenous community engagement, in health research, and things like OCAP principles, where research that's being done reflects what communities identify as important versus what researchers think are important. This can include grounding research in a strengths-based and resiliency-based lens versus a deficit lens, and making sure design and methodology reflects the values of communities. And if all of those reasons, moral, ethical reasons don't speak to you, it's also important to consider that the health services and research landscapes are increasingly emphasizing the importance of patient engagement in health research and services. More and more institutions are recognizing the importance of lived experience and other ways of knowing. For example, here at the University of Manitoba, forging connections to foster high impact community engagement is one of the current strategic priorities. And Manitoba Shared Health emphasizes person-centered care and engagement of patients and the public in its Manitoba Quality and Learning Framework and the Clinical Preventative Services Plan, which they're rolling out, and with related activities, a lot of which are involving engagement with patients and the public. Increasingly, funders are asking applicants to allocate a portion of their proposed funding to compensate people with lived and living experience, and asking you to demonstrate a well thought out process for involving them in research decision-making. This also includes health systems and service delivery organizations, who often also provide funding for health-related research, such as hospital foundations. Additionally, many journals are involving patient partners in the review process, such as BMJ, while others even require reporting of engagement in the research process. We have heard from researchers in hindsight that involving people early on would have helped them identify limitations they could have overcome, and even if you engage at the dissemination or reporting stage, people could help you identify strengths and limitations for publication or future research that you might not have considered. And it also presents a unique opportunity in research, in that if you engage early and keep detailed records of the methods and outcomes of engagement, you can report on both the research and the engagement process itself. I see someone in the chat has mentioned GRIP 2. So that's a reporting checklist. I'm trying to remember where it was developed. I'll throw a link in the chat to it once I turn over to Victoria, but it's got a list of the different things you want to think about, even when you're starting to engage, that you want to keep track of, that you want to consider, that are going to be required by some of these publications. So thank you for mentioning that in the chat. I really should have included that. And as I mentioned, I'm going to talk briefly about the levels of engagement. It's an important aspect when you're thinking about planning and engagement strategy, thinking about the level of decision-making power that will be shared with patients, caregivers, families, and communities you want to work with. Whatever level you choose, it should be made clear to your partners what decisions they're able to inform and how flexible you're able to be about these decisions. So, for example, you may want to involve patients in deciding on outcomes, but you know that there's a specific measure, a clinical measure that's non-negotiable in your eyes. You need it to be able to compare with other studies. You need it to be able to publish in your field. So that's something you would want to just be clear about when you're working on those outcomes. The lowest level on the left there, this is from our group. There's other different definitions and scales of engagement, but the lowest level for us is consultation. So this primary goal of consultation is to obtain feedback or input, and the decision-making power here lies solely with the researchers. This is often about getting feedback from patients on research priorities or questions that have already been developed by the research team. And it involves a variety of engagement approaches, which could include surveys, forums, public and town hall meetings, focus groups, interviews. And while this does involve collecting information from folks. It is very different from collecting data from participants in a research project who you would consent, as this input is on the research process itself and related decisions, and not so much perhaps on the outcomes. The involved level, it involves working directly with partners, especially in the planning stage, to ensure their hopes and concerns are understood and considered, and the research process directly reflects what they say. A step up from consultation, because people actually have some say in decisions around the research process, things like priorities, the research question, the design, methods, interpretation, or dissemination, but researchers still hold the ultimate decision-making power. Common techniques used or in participatory approaches used for the involved level include things like workshops or having folks on advisory committees. At the collaborate level, we are actively partnering with people with lived and living experience to make shared decisions about aspects of the research, including things like grant writing or publication. In this context, we might use participatory decision-making or even have patient partners as research team members who work alongside us throughout the research process. This level, once we get here, it requires real commitment, trust, and relationship building. It requires research teams to be open and flexible, and it takes a substantial amount of time and resources and planning and preparation to execute. And then finally, at the far right, we have the patient and public directed level of engagement, sometimes also referred to as user-controlled research or citizen science. This is when patients and or members of the public actively control, direct, and manage the research process. They decide the issues and questions and how to do the research, and are often the ones doing it. The role of the researcher at this level may be to take a back seat. They might provide support through training, research skills or infrastructure, and administrative assistance. Decision-making ultimately here is in the hands of patient and public partners. And this is another example. This is from the International Association of Public Participation. It also shows engagement as a spectrum, where at one end we have that push of information outward from the research team to people with lived and living experience. And on the other hand, we have people taking on the role of researcher themselves and leading the process. This might include like grassroots research initiatives, for example, led by community organizations or groups that then bring in a researcher afterwards. And then there's all this space in between where we can have various degrees of decision-making power and control over different aspects of the research process. Now, that was a lot of information, especially if you're new to this. Now I want to share with you some tools and resources that can help you better understand how you might do engagement in your own work and plan out a tentative engagement strategy. Ideally, you would want to work directly with patient and public partners from the get-go to decide how you're going to engage, what you want to engage about, what kind of research you want to do, but that's not always feasible or realistic. So a common approach that works well is to work within your team to develop a draft plan and then bring that to partners to rework and refine. So that said, this is our lovely patient engagement team. You can connect with us. I'll share some information in a follow-up email and perhaps in the chat. We can help you work through the process of patient engagement, including it in your grant, compensating partners, developing strategies for recruitment and engagement, and just practical advice for the steps involved in actually doing engagement. And there's probably even some folks in our audience who have reached out to us from time to time to say, oh, I'm stuck with finance. I don't know how to do this. My grant's ending. How do I compensate people? How do I recruit people? So we are here to help. Please feel free to reach out. What we are currently experiencing, the PE Lunchtime Learning Series, we hold this monthly, usually September to May or June. We have all of our previous sessions recorded and on our YouTube, which is the link there. I will share all of these in a follow-up email. You can also sign up for our newsletter to hear about upcoming sessions. And again, I'll provide the slides and links later. We do provide free 1-hour consults to help you get started with patient engagement. We'll provide specific tailored resources, and we can also talk about what kind of fee-based services we have, things like team training, facilitation. We have a blog series, so a lot of peer-reviewed and expert opinion shared in easily digestible short format for you to get you started in patient engagement, especially if this is really new for you, and that's our PE 101 series. And we have a ton of other articles on practical aspects of patient engagement and some methods as well as trauma-informed approaches to engagement. So it's a fantastic resource. And we have a whole schwack of online resources on our webpage. We have a guide to the different methods you can use in patient engagement, like participatory decision-making, workshops, all that kind of thing, with additional links to resources there for more info. We have a budget builder that you can include in your grants, including the PrEP award if you're planning on applying for that. It'll help you work through the different things that you might want to consider when building a budget. We have a readiness to engage workbook for teams, which takes you through some critical reflexive practice questions, both as individuals and as a team, to consider your own location, your perspectives, your biases, before you think about how and who you want to engage. We have a list of low-cost and free counseling for Manitobans, and a one-pager recruitment guide that lists pretty much everything you would want to tell patient and public partners when you're looking for them out in your circles or online or what be it. And now I will turn it over to Victoria to share some specifics around engagement in data science, tech, and engineering. Victoria, I'll stop sharing.
Thank you, Trish. Okay, so now to make this all a little bit less scary, we'll give you some real examples of people who have done these sorts of things in data science, technology, and engineering. So to start off, just a bigger picture of what's going on in these fields right now. So right now, the patient engagement tends to happen at the later stages of the research, so more focusing on that dissemination process and how to reach audiences that the data might have been based off of and to educate them. However, as we've discussed through the portion of the presentation so far, involving these patients and public partners earlier on can give you even more options to create more meaningful and relevant research based on their feedback, even earlier stages. So the first example is from the National Institute for Health Research in the UK, and they did a project on child prosthetics. So how to design them that they are the best for the children actually wearing them. And they were focusing on creating activity limbs for children, so those that they could use to run or swim, for example. They established a child prosthetics research collaboration team, and this team involved the children and their family, including siblings, as well as leaders from the healthcare area, academics, and industry. So the first thing they did with this group is conducted overall needs assessment of what's going on, what are people thinking about, and what needs to be considered when we're talking about designing these sorts of prosthetics. So from that perspective, they looked at, well, we need to contact clinicians, but they're very busy people already. We're not going to bother them with workshops and focus groups. We're going to send them an online survey, quick and easy, and they can move on with their day, but they still contributed their feedback. But for children, they focused a lot more on getting them engaged in the way that they would be most comfortable and build relationships over time. And so they focused on making workshops with kids and having paper-based questionnaires that would focus on drawing and more self-expression ways instead of just giving them a survey with a bunch of questions on them. So here's an example from some of the projects they did. So they had people sitting around with their kids. They would draw things. There would be some prompt questions like having a limb is super because, and then kids would draw in what is so super about him. And having, for example, even thought bubbles, so kids could draw in little ideas and just stick them wherever they came up with that idea that needs to be mentioned. The second part, after completing the needs assessment, they used to make a full-on StarWorks project, is what they called it. And these would be collaborative events with all the 4 stakeholder groups. So the kids and their families, the clinicians, academics, and industry people. And first started off these workshop days with the problem definition. So each of these stakeholder groups would actually present their perspective on what the issues are in their own words and what matters to them the most. Then they would have a stage where they would try to form a bunch of ideas. And so the researchers aided this portion by having guest speakers and people who are involved in the innovation of these limbs come and give people ideas of things like what they need to consider when we're talking about designing prosthetic limbs, but also giving them a lot more options for what to think about when they do design them themselves. And in this portion, they would give out these handouts to the kids, and they'd have a big blank space to draw their own designs of the prosthetic limbs. But they also had questions around the entire page of kind of prompts to consider when they are thinking about these. So when is it going to be used? How can different people use it? How easy is it to take off, for example? So just things to make sure that all bases of the design are covered when it is being created. After they did these, they actually did a voting to pick the top 5 designs, and they just plastered them all on the wall, and people would go by and put little stickers on which ones they voted for the best. And then they would further try to establish future collaboration with the people that showed up to these workshops, and they gave them this sheet at the bottom right-hand side. So asking them, which projects would you like to be involved in of the top 5 that we've picked, we've all decided are the best? How can you be contacted? Giving them the option for phone, email, is it in person they would prefer? And also asking them what specifically they would want to be collaborating with. Do they want to just actually participate in the design and help out in any way they can? Do they want to be just contacted for advice and questions about it? Or do they just want to receive an update of how things are going? And maybe then they'll decide if they want to contribute more or not. So what they got out of this StarWorks project is 234 new design ideas for prosthetic limbs. And they grouped these ideas into 59 problem areas or themes identified. And 15 of these 59 were things that the original designers have never thought of before. And so these are 15 new ideas that are going to improve the way that prosthetics are designed and how they can be made easier for kids to wear and have them have more independence from their parents so that they don't have to be assisted in every portion of their day where they might be right now. The second example is for data science specifically. So there is the least amount of patient engagement probably going here, and I had a very tough time finding good published examples for this, but I'll start with this one that kind of gave it an overall picture of what we need to consider. So this is looking at a palliative and end-of-life care, and these researchers use a lot of pre-collected health data that is in our health systems to guide and predict different outcomes for people who are in palliative or end-of-life care. So they formed a public involvement workshop, and the theme was to discuss these large data sets that are used in research in these fields. And their goal was to explore the public view of what their involvement could be and what do they even know about what we might call big data or data science, whatever term that is in the media right now that's catching on. And so the attendees included patients, carers, and public representatives who had lived experience or have any interest in palliative or end-of-life care. They did a workshop where they laid out first to introduce concepts of big data research to the people who attended. So really just giving them an overall idea of what this field is, some of the typical terminology they might come across when interacting with this sort of research. And then they would go on and hope that this could aid the group discussion around this sort of data. and talking about how much it's available, how it is to access, talking about the advantages or disadvantages that both groups might see with using this sort of data, talking about data governance and the ethics behind it, and also a challenge of or the discussion of the challenges, opportunities, and values of involvement of the public in this big data research. So what they found was that not a lot of people were aware of even the concept of what big data was, or that it was even being used in research, what kind of data that actually meant. Like we talk about, yes, it's found in our administrative health data, but what is actually in there? Is it our demographic information? Is it our diagnoses codes? So we need to get way more specific about what we're talking about when we say routinely collected data, for example. And so that was one of the other things, is that there was a barrier to involvement in the jargon that comes with this field. And so we just need to be very specific and break down as much as possible. And so that's why it's important in these sorts of patient engagement initiatives to first start off with breaking down the sort of jargon and first going through what the research field entails. But the opportunities that the public identified through the workshop was quite a lot. And so I'll go through the few main points. So the first is that the public is very, wants to be involved in this sort of research, but it needs to be very much laid out in clear terms for what the terms are that they use and the jargon. How does data access actually happen? What is that process that researchers have to go through? We are quite comfortable and know that it's safe, but the public does not know all the details of how hard it is to get into the data that's housed at, for example, Manitoba Center for Health Policy. So they also want to know more about the data content that is housed within these data sets. How is it anonymized? How is that transfer process done? And how does the confidentiality remain intact for all the patients that this data is based off of? So they also want to be involved in the priority setting. So if they could have access to knowing what the data set is about, what it contains, they can also help guide what should be looked at the most in there. Maybe there's something really critical that we haven't even considered. And the third point is that they can provide a personal narrative to the research results and trends. And I like this term they use, to humanize the data. So instead of speculating on what sort of results we got, why we got them, we could actually ask the people that this data is based off of, what is their interpretation of why things turned out the way they did in our models, for example. Further, they would like to advise in future research questions based on the current results. So just because we got a certain trend or result, they can point us in a better direction of why it might be relevant, or maybe we're going in the completely wrong direction. And lastly, the public felt very confident that if they were more involved in points of advocating for data governance and informing data and research of this type, they could also actually push the decision makers to create newer data sets and more standardized ways of collecting this sort of data. And so having the public involved would actually push us to have better data quality and more standardized ways of collecting this data than we do right now, which is quite a big mess. And the third and final example is in technology. So this one's looking at digital therapy for adolescent mental health. And so in this, the researchers identified the problem that youth have very high rates of depression, anxiety, and self-harm, but they actually have one of the lowest rates of help-seeking behavior for mental health services. And so their goal was to engage with youth in New Zealand, specifically, the study is from, to understand what their actual preferences are with online tools for mental health, and how do they even use them? What would they prefer to be in there? Are they even interested in having online tools for their mental health in the first place? And so the attendees of this workshop were youth of Maori and Pacific descent. So this is again happening in New Zealand. They designed 4 focus groups, which took place with Student Health Council, the community youth, and 2 focus groups with the extended family of the youth that were attending. And then they also did 2 workshops on top of this. Within these activities, they were all given a tablet that was preloaded with a bunch of currently existing mental health apps and websites. So they were given, this is all the stuff that's the best of the best that's existing right now. What do you think about it? And so they were asked specifically to think about the following questions. So what is their current behavior around these resources? And do they meet their needs for what they might be looking for their current mental health? Their preferences for where the resources are or how they're going to get to them. Do they want it to just be as simple as a Google search and it comes up exactly what they want? Or do they want a pre-existing kind of map or something that tells you this one might be the right one for you, for example? And also asking about content delivery. Do they like it? Do they just sit down and read it and they move on with their life? Do they want a video where they can more interact? Do they want to play it in a game form so it's a lot more interactive on their end? And also, how would they prefer to receive feedback on how they're doing? If they've, for example, done some prompts and some gratitude questions, for example, how do they want to receive the feedback that they were doing what they could best for that day? So the activities of all of these tablet apps and websites, they went through either discussing them, just an open discussion with everybody else who was attending. They could sketch their ideas out of specific things that made them think. They could tell stories about why they might feel the way they do for a specific resource, for example. And they did what they called wall storms. So they just wrote a bunch of ideas on sticky notes and posted them on the wall, and people would go up and reflect on them and kind of further lead a discussion based on the wall storm. So from this, what the researchers found is that, number one, these resources they're trying to design and push for are very unlikely to succeed if they just depend on the youth coming and seeking out these resources themselves, because that all youth completely admitted that, no, I'm not going to go out of my way to go look for this. I'm going to go and, I'm going to have a different life. I'm going to have a lot of challenges with my peers in trying to look for this sort of information and seeking help. So there's just a lot of life barriers that don't let them go and seek out these openly. The second was that they wanted the help to be for here and now, for in the moment that they are living, and not for things to work on for the future self. They wanted resources that would help them of how they're feeling today, and not how they might feel in 3 months from now once they've finished this program. And the third one was that the one idea is very unlikely to appeal to all youth. So their initial idea of just doing a one mental health resource after engaging with youth was completely out the window, because they realized that everybody is incredibly different in what their needs are and what their mental health status is. So what they actually came up with is this little taxonomy based on just what they heard from the discussion groups, and they kind of tried to group people together. So on the y-axis, you have younger and older age groups, and on the x-axis is how much they are actually experiencing stress or low mood. And so they found it to be those that are the least stressed and the happiest tend to also be the younger youth. And they really like the idea of games and playing and interacting with things, but they don't necessarily feel that they need these resources yet. And on the other end, you have people who are youth that are much older. They are experiencing stress and low mood on a regular basis, and they just want it straight to the point. They want to read about it, they want to know what they can do, and then they can move on and do other things throughout their day. And in between, you have other groups, such as those that are willing to engage and they are looking for that information as well, or people that are completely skeptic and they might need a little more selling. And so there's different resources that need to be designed for each of these groups to feel like they are getting what they need for their current mental health. And so the lesson learned, there's this quote in the article at the end. So acknowledging young people's lack of help seeking and diverse perspectives is critical to successful implementation of digital mental health interventions. And here is a screenshot of one of their apps that they've designed since this research was published. And so this is to tackle those that are really into games and interactive ways of dealing with mental health resources. And so this one, they made a game out of cognitive behavioral therapy. And it is, I'm pretty sure, available in the App Store already. Alrighty, and that is that.
And so to tie this kind of all together into why we're telling you about this, we have the Preparing for Research by Engaging Patient and Public Partners Award. We had a general call that closed back in November, but we are still seeking applications specifically for projects that are looking to engage in technology, engineering, or data science. And this is to honor Dr. Wadaminster Sakoldi, who was a colleague of ours who passed away unexpectedly about a year ago now. And so we've established this award in her honor. She was a really big advocate for patient engagement, specifically in the use of administrative data. So we would be more than happy to support a Manitoba researcher, student, or organization who is working on research in this area, who's looking to engage patient and public partners in that early design and planning phase. So I'm going to pop the link to the PrEP award page in the chat. And our website there, you can reach out to us if you need any help preparing your application. If you're curious about eligibility, please don't hesitate to reach out. We are here to help. We just want to see patient engagement being done in as many projects and fields as possible so that people with lived experience can really have a say, and we can do better research. And I think we're getting close, so I'll open it up for discussion, but I will stop recording so that folks feel more comfortable.